Thank you. Good morning, everyone. Okay, before I start my presentation, I would like to pay my respect to the traditional owner of the land. This is my second time in Brisbane. I hope I will present what happened in my country to all of you. Before we started, I'd like to explain my country. Some of you already know. Some of you last night asked me where is you from. So as we can see in the slide, we are between Indonesia and Australia. We are close from Darwin, like we fly like for 45 minutes. Darwin to Delhi to Darwin. Delhi is the city of the country. Yeah, we have around 1.3 million population in our country. Yeah. So the history, we are history of Portuguese colonization and then Indonesian invasion. So we just independent in 2002. Our health situation in Timor-Leste is a little bit slow. So this is introduction for my country, and let's talk about HIV in Timor-Leste. Before, you can see this picture, they are on my team. Not only my team, but they are my family. So we are small, we work in the small clinic. It's called like, the clinic, it's not a big hospital, it's a community clinic. It's called Maloa ART Center. So its clinic is like, started in 2018. It's cooperation with the Maluku Timor and Minister of Health. And now we have like 39 pregnant amongst 33 women in our clinic. As we can see in this slide, this is the result that we have a lot of women that diagnosed late. They already have a CD4 low, they already had a perioditis infection. Usually they have TB, they have candidiasis, and most of them, they diagnosed like pregnant late, like already 3 trimesters. It's mean that difficult to us to like try to do the treatment to reduce the viral load as soon as possible better. But it's not easy because they already come late. We just start ARV today and 1 week or 2 weeks after that already delivery. Yeah, something like this. But all of the pregnant women, we started appropriate ART pre-delivery. As we can see in this, 95%. But the viral load suppressed, the number is decreased, 83% during pregnancy. But we can see after breastfeeding, it's only 50%. So my question is, what has happened, right? And then we can see in this one, infants, we give the antiretroviral prophylaxis only 6%, and early infant diagnosis down to 45%. Yeah, this is happy. Even we can start the appropriate antiretroviral 95%, but it's not enough. The number of the testing, the number of the viral load is like decreased. What is the problem? What is the challenges? As we can see, we have a lot of challenges, but I can mention in this slide that most of our PLHIV, they live in remote areas. It's like difficult to them to access, and the road is bad. Some of them, they have no money for getting the transport. And you can see, this is my photo that I went to another district to do the home visit. I do the consultation inside of the car. There is the stigma discrimination high in Timor-Leste, and the patient feel not comfortable to attend in-house. So I have to bring her out, like go to the sea, something like this, and do the consultation. Another challenge is that it's a big challenge that we have a general population, they have a low knowledge about HIV. It means that increase the stigma in our country. What we can do for this one, we do the media campaign, We give the video, we do the video and share the video. We do the workshop, we do the seminar to the young student to give more information about HIV. And it's not happening only general population, it's happening also in healthcare workers. They have a low knowledge about HIV. And the stigma discrimination in hospital also happen in my country. And what we can do for this one, do the training to healthcare workers about HIV. They can know words about HIV and develop some book about HIV, writing in the Tetun, the linguals on the Timor-Leste, so they can read and they can know about HIV. Another challenge that we have that sometimes we have a stock out for the test and we have a stock out for the antiviral prophylaxis, nevirapine, zidovudine. Now we have no zidovudine syrup in our country. Only nevirapine, but the stock is limited. It is happy. Sometimes we have no test for the profile DNA. We use viral load. It's like another way to diagnose to the baby was born with mom with HIV positive. In other, the photo that we saw is this our guideline for the nevirapine and syrup prophylaxis to the baby born from mother with HIV positive. And what we can do for all of the challenges, what we can do in the future in my team, like now we work in the new project, the triple elimination. Right? We work the partnership with the Asian from Australia, and we started a little bit experience from Papua New Guinea about this project, and now it's implementing now in our country. We continue doing our media campaign. One day before I came to Brisbane, I was talking in TV in public TV about the HIV. So give more information about the HIV to general population and to people who live with HIV that cooperate with the treatment. Please come back to have a treatment. Something like this that I talk with in the TV. And also what we can do for our team. Our team is try to make a good strategy, improve our service to our PLHIV in Timor-Leste. For the last one, I would like to say thank you for people living with HIV in Timor-Leste. I'm here because of them. I represent all of people living with HIV in Timor-Leste. I would like to thank you to my team that always support me, and thank you to Virology Education for sponsoring me to attend this international workshop in this year. Thank you.